Hello to everyone, and welcome to the third webinar of the Undocumented Alliance series on migrant and refugee health, entitled Ensuring the Covid-19 Vaccine Reaches Undocumented Migrants, organized in cooperation with PICUM, the platform for international cooperation on undocumented migrants. My name is Luciano Saso, and I'm a Vice Rector of Sapienza University of Rome and member of the Executive Committee of the Undocumented Alliance. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at the annual event in Berlin, at regional meetings, and at more specific expert meetings. In this difficult and tragic COVID period, we are organizing now monthly webinars. We started in January with an event on the impact of COVID-19 on migrant and refugee health in cooperation with the Lancet Migration Commission. And we continued in February with another one on migrant health issues in massive migration areas in the COVID period, in cooperation with the Association of Academic Health Centers International. On April 19th, we will have another webinar on digital solutions for migrant and refugee health in cooperation with the London School of Hygiene and Tropical Medicine. On May 27, we will have another one on how can strengthened healthcare for migrants foster health for all in cooperation with the NGO Emergency. More information and the link for free registration is available at the World Health Summit page dedicated to migrant and refugee health. For the meeting today, I would like to thank very much Alina Smith from PICUM and all distinguished speakers for accepting our invitation. Thank you also to Stephen Matlin from the Institute of Global Health Innovation of Imperial College London, who will be the rapporteur of this meeting. For the organization of the webinar, I would like to thank very much Nora Anton and her collaborators of the World Health Summit team. I would like now to give the screen to Alina Smith, who will chair the panel. Alina is a senior advocacy officer at PICUM, where she leads the organization's work on access to healthcare, access to justice, and legal strategies. She joined PICUM in 2015. She is a licensed lawyer and has previously worked on matters related to health policy, migration, and human rights. Alina has an academic background in law, bioethics, and life sciences. I would like to thank very much all the participants for being online with us today, and I invite all of you to ask questions in the chat in view of the discussion, which will be open after the presentations. I wish you a very pleasant and fruitful meeting. Thank you again, Alina, and please, you have the screen.
Thank you so much, Luciano. First of all, for the opportunity to jointly host this event with the Undocumented Alliance. It's really, really a pleasure for us to, as PICUM, to have this collaboration. And it's really, really a pleasure for me to chair this very wonderful panel. I think we're very, very fortunate to have the folks we have with us this afternoon and this morning, for those of you joining from other time zones. We have really rich perspectives coming from academia, coming from colleagues from NGOs, coming from public health authorities. So I hope you're looking forward to hearing from them as much as I am. And thanks to all of them for joining today, and to our participants. So we're going to kick things off with a presentation from Michelle Lavoie, who is the director of PICUM. Michelle has been director of PICUM since 2006, and she sits on a number of different boards and advisory committees. She does advocacy also at the global level, where she has a rich network of colleagues and contacts. And she has a master's degree in applied sciences. And Michelle will provide an overview of the situation that we see in terms of undocumented migrants' access to the vaccine for COVID-19 in the European context. Michelle, I give you the floor.
Thank you, Alina, and thank you, Luciano. And also, just to re-echo what Alina has just said, we're very glad on behalf of PICUM that we can host this, co-host this today. I think this is a very timely discussion, and there's a lot of work actually to be done, both by policy experts, by civil society, researchers on this particular focus of the vaccine for COVID as well as undocumented. So I'd like to start by going to the next slide, please. And basically thinking about when we're talking about the COVID-19 pandemic, how has it affected undocumented people? And so in order to look at the vaccine and the access for undocumented, first we wanted to start with this. So next slide. So before the pandemic, being undocumented, as it still does now, means limited access to decent work, wages, living conditions that make it really hard to follow all the physical distancing measures that we've had to see now with the pandemic. Some undocumented face extreme living conditions, immigration detention, informal settlements, camps, sleeping rough. Many undocumented people work in sectors that are under-regulated with precarious work permits, limited protections, and this includes food delivery, cleaning, construction, agricultural care work. So undocumented during the pandemic have either continued working, but with limited access to protective equipment, or been unable to physically distance, or they had to stop working, they lost their job, and becoming destitute because they generally don't qualify for income support. Next slide. In October last year, the OECD published a report that looked at the impact of COVID-19 on immigrants. This slide has some figures from the report. It's interesting to look at one of their quotes. So the OECD said, the negative impact on immigrants' labor market outcomes is increased by the fact that they're strongly overrepresented in sectors that are most affected by the pandemic. For example, in the particularly hard-hit hospitality industry, a quarter of employees in the EU are foreign-born. Migrants who are undocumented aren't represented in the OECD figures, but we know from our network and from the reality on the ground that this is also the situation for them. Next. So when we also want to look at how undocumented will be able to access the vaccine for COVID or not, we should also look at in general, how are undocumented people able to access healthcare in general? We see that there are limited entitlements as well as access to primary healthcare under national laws in most EU countries. Even when these laws might exist, there's numerous administrative barriers, there's complex procedures that make it very hard to actually access what they might be entitled to by law. And they risk immigration enforcement if they try to seek care. This risk of immigration enforcement, it's related to the broader policy environment, which in general criminalizes irregular status and means that people who become known to the authorities because they're undocumented, for example, a labor inspector or an undocumented person who reports to the police, or sometimes when they become known to authorities because they want to use their healthcare entitlements, they face possible deportation. We've also seen in Europe in general that criminalizing irregular migration also means criminalizing efforts to help undocumented people. So for example, volunteers or people at organizations who might be penalized because they're trying to save someone from drowning in the Mediterranean, or transporting someone across a mountainous area to prevent them from hypothermia, or giving undocumented people accommodation. So this criminalization of migration has generated mistrust. And this is very important to consider when we're talking about a vaccine rollout for undocumented. Next slide. Now, if we look at the response to the vaccine itself, what's been very interesting is to see numerous international bodies in recent months who've provided clear guidance on reasons why they should include people with undocumented status in the vaccine rollout. In November last year, the WHO issued some guidance on deploying national strategies, emphasizing that the public health dimensions of inclusive approaches are crucial and that no one is safe until everyone is safe. WHO has also placed an important emphasis on equity as the guiding principle, both global equity in ensuring that the vaccine reaches everyone, regardless of where they live in the world, as well as nationally recognizing that some people might be at a greater risk of COVID-19 because of systematic factors. The IOM has reinforced the need for deployment strategies to include migrants, regardless of status. And UN human rights specialists have also spoken to remind countries that it's a duty that they have to ensure that migrants, regardless of status, get the vaccine as a matter of human rights. Next slide. But what does this look like in practice? So on the one hand, we have these wonderful statements from the international agencies, and how are national level authorities then translating some of this guidance? Within PICUM, we've been trying to monitor these national strategies and the measures that are being implemented. And we've been doing this by monitoring media reports. We've been gathering information from our members and partners that work in the national level. So this map that you see here is what we've collected so far. We've identified so far 7 countries in Europe who've indicated that they would like to include undocumented people in the COVID vaccine strategies. These countries are Belgium, France, Ireland, Italy, the Netherlands, Portugal, Spain, and the UK. And this is also still incomplete. We're still monitoring it. And next slide. What I wanted to do very briefly is give you some examples of these countries that are included. So the UK. The UK announced in February this year that all residents could access the vaccine regardless of status. The only requirement would be to register with the GP, which is available to everyone in the UK. The government has translated information about the vaccine into more than 10 languages. And this all sounds extremely promising. However, NGOs have expressed concern that the UK's policy of a hostile environment towards migrants might undermine vaccination efforts. The hostile environment discourages migrants' use of healthcare by charging them, and where they might have health-related debts might actually have immigration consequences that could lead to deportation. So all this has also created a climate of mistrust. Next slide. Ireland, and you can click again because there's a quote there that appears, thank you. Ireland has been explicit about including undocumented migrants in their vaccine distribution. The Minister of Health himself has stated clearly that there won't be any consequences immigration-wise for people who come forward. And the minister has encouraged undocumented people to come forward to get vaccinated. It's also useful to note that last year at this time during the lockdowns, Ireland announced that undocumented people could get access to COVID-related care without the risk that their personal data would be shared with immigration authorities, and also that they would be included in Ireland's pandemic protection program for workers who lost their jobs. Next slide. Spain is an example where the National Vaccine Plan has said that undocumented people should have access to COVID vaccines in the same way and according to the same criteria as the whole population, most likely qualifying as people in a vulnerable socioeconomic situation or qualifying as essential workers. So under this national vaccine plan, undocumented people in Spain should have access to the COVID vaccine in the same way as basically the whole population. Next slide. The United States, we're going to hear about on this panel. Very much look forward to hearing about that. But I wanted to highlight just briefly here that in terms of the rationale for vaccinating undocumented people, the language from the US Department of Homeland Security underscores that it's both a moral as well as a public health imperative that undocumented people can receive the vaccine. The Department of Homeland Security is clear in its statement that ICE, which is basically the Immigration Enforcement Department, will not conduct enforcement operations at or near vaccine distribution sites or clinics, hospitals, doctors' offices, or urgent care facilities. Next slide. So this obviously sounds very promising, but what have our members within PICUM and other national level organizations identified as challenges to enable undocumented migrants to access the vaccine? So we've heard from organizations based in Belgium, the Czech Republic, France, Germany, Greece, Ireland, Italy, Luxembourg, Norway, Spain, and the UK. And these are some of the challenges that they say still remain. So there's the fear about personal data being transmitted with the immigration authorities, administrative barriers, lack of accessible or reliable information, unclear policies or procedures, lack of consistent implementation when this is done on a regional level within the country, and also this necessity of 2 doses for the majority of the vaccines. And this is an issue for people who might not have a fixed address, who might be hard to reach by a GP or public health professional. Practically speaking, for people who are already kind of vulnerable because of their situation, going to the vaccine center twice is an issue, as well as the fear or the distrust maybe having to deal with that twice. And so the next slide, almost there. In terms of going forward, what our members and other national level organizations are recommending and what they're also seeing as potentially good practices are some of these. So they see that it's a good practice when there's governments who give clear instructions about how undocumented can access the care they're entitled to. For example, the UK government that published the COVID-19 vaccine guidance in 11 languages might be an example. Another example is clear commitments from the government that the undocumented migrants' personal data will be safeguarded and that there won't be any negative immigration consequences if they come forward. Ireland is given as an example here, in Belgium, although we'll hear from Frank on the panel about Belgium, so we'll see how much that resonates. Limited documentation required to register for it, a simple process. NGOs who would be actively involved in helping to define the strategy and the protocols for undocumented, as well as multilingual communication and outreach campaigns. And the last slide here is just 3 takeaways or 3 conclusions. So basically, we've seen that the realities of undocumented that have now been magnified during the pandemic are nothing new. Basically, what the pandemic has shown is that it's made them more visible. So the public inequalities that have existed for years have become more visible. And at the same time, we've also seen what governments are capable of. I mean, there's been some very promising practices, not only in the area of healthcare, but also in terms of releasing people from detention, temporarily halting deportations, extending residence permits, etc. So I think that's the first point. The second point is why would you actually ensure access to the vaccine? Well, first of all, public health, but also fairness and morality. So these are reasons that are not necessarily just for the vaccine. These are reasons for enabling undocumented migrants to have access to healthcare more generally. And it's a way to improve their health outcomes and access to healthcare. And the last point is that we have to keep an eye on the gaps that still exist in our health and our social protection systems. And so the pandemic has shone a lot of light on them, but we have to remember that these gaps are still there. And so we have to address them going forward so that we can protect and benefit all members of society, regardless of their immigration status. Thank you very much.
Thanks a lot, Michelle. Thanks for reminding us of the international recommendations and guidelines that exist that really are really pushing for an equitable approach to vaccine distribution. And also for reminding us that really I think in many of the countries we're going to hear more about today, the background, the context we're speaking of is a context where irregular status tends to be really criminalized. And so that is a really important context to bear in mind when we think about health-seeking behavior, when we think about the effectiveness of vaccine rollout strategies. And you've also given us a picture of the great differences among countries, even in Europe, in terms of their approaches, in terms of their stated intentions of including undocumented people, and even potentially discrepancies at the national level in terms of rollouts regionally within a given country. So now we really have a great opportunity to hear from a number of speakers about what is happening at that national level and really go beyond the standards and the recommendations to what is being actually contemplated and implemented at the national level. And our first speaker to really bring us insights on this national context is Johanna Offe. Johanna is advocacy officer at the German chapter of Médecins du Monde, Doctors of the World, where she mainly works on issues of migration and health and access to medicines. She has an academic background in sociology and anthropology and a PhD in anthropology. So it's Dr. Offa. We're very, very happy to have you today. And bearing in mind the background of criminalization, I think it's very interesting and important to hear about the case study of Germany and what we can learn about the situation there. So I give you the floor.
Thank you very much, Alina, for the kind introduction, and to all of you for the invitation to this interesting panel. Let me start by quickly describing the domestic projects of MDM Germany, because not all of you might be familiar with our programs. Let me see, this doesn't work. Sorry. Now. Médecins du Monde, Doctors of the World is an international humanitarian organization engaging for the human right to health projects in many areas of the world affected by crisis and conflict. In addition to these international projects, each of the 16 chapters of MDM has domestic projects providing medical services and social support to people with limited or no access to healthcare. In Germany, we have clinics and or mobile services in 4 cities, in Berlin, Munich, Stuttgart, and Hamburg. And we roughly see 2,500 patients per year. And we also collect and publish data on the barriers keeping them from accessing healthcare in the regular system. Our services are free of charge and anonymous if wanted. And we always combine the projects with advocacy on the human right to access healthcare. The majority of our clients are undocumented third country nationals and unemployed EU citizens without residence right. In the context of the COVID-19 pandemic, as Michelle already said, our clients face particular hardships. Access to information is limited. In the beginning, almost no information was available in other languages. Many of our clients cannot protect themselves from infection because masks, disinfectants are not available, and they live in crowded housing situations. In addition, undocumented and uninsured people had and still have limited access to testing. At first, it was undocumented migrants were only entitled to get tested if they were a contact person, not if they were themselves symptomatic. So they also have limited access to treatment because they do not have health insurance. And in addition, they were often highly affected by the lockdown measures, as they often lost their work in official jobs in restaurants, in cleaning, and in childcare. In addition, services for these people were often interrupted. Many voluntary organizations couldn't keep their services open because they didn't have enough protective gear, or because they themselves were at risk because many of them are elderly. Before I come to the vaccination situation now, I would like to say a little bit about the healthcare situation for undocumented migrants in Germany in general. Undocumented migrants de facto do not have access to healthcare in Germany. The last estimate from 2014 found that 180,000 to 520,000 undocumented migrants live in Germany. They are legally entitled to restricted health services. However, there's a duty to report for all public authorities, according to paragraph 87 of the Residence Act. While educational institutions are now excluded from the duty to report so that children of undocumented migrants can visit schools, for instance, the social service departments, those that are responsible for covering the cost of health services, are still obliged to immediately report someone without residence right to the police. So I've tried to show the process in this illustration. An ill person would have to go to the social service department before going to the doctor in order for the cost to be covered. The social service department, however, is obliged to report the person to the immigration office so that the person will then be arrested and probably deported. Thus, undocumented migrants, of course, avoid medical care, and the exceptions that do exist for emergency care do not work properly, as hospitals are usually then not reimbursed. So what is the situation regarding COVID-19 vaccinations? In general, vaccinations are included in the Asylum Seekers Benefit Act. So there is an entitlement also for undocumented migrants. The cost for COVID-19 vaccinations in the official vaccination centers is covered independent of existing health insurance. So that is both pretty good, but the vaccine regulation entitles only those with habitual residence or registered address in Germany to get vaccinated. Of course, then grouped in priority clusters. Regarding the term habitual residence, there are different legal interpretations in different laws in Germany. In some, residence is only considered habitual if it is legal. This would thus include and exclude undocumented migrants from access to vaccination. The duty to report, again, is not a major barrier to vaccination in the vaccination centers, as they are not public authorities and they are led by doctors. But legal uncertainties exist here as well. The situation in practice is very inhomogeneous and very much on the move right now. So I'm trying to give a picture, but it's not final yet. So the implementation of the vaccine regulation, the federal vaccine regulation, is organized at Länder level, so at state level. And in many cities, the vaccination of priority groups is done only after receiving an invitation letter, which of course depends on a registered address. Plus you need a phone and internet and an email address. It's actually quite complicated to get vaccinated. Then again, the vaccination centers demand personal ID. So there is a de facto condition for a legal residency. And hopefully mid-April, the vaccination will be possible through GP offices. And then some costs are covered through health insurances. And this might be a problem for undocumented migrants because then the duty to report comes back in. MDM did a very quick survey and among organizations providing services for undocumented migrants, and I thank everybody replying to that. We got feedback from 11 cities showing how different the situation is and also showing that undocumented migrants have not been included in vaccination strategies at local and regional level. The best situation is probably in Thuringia with the left government, which recognizes the entitlement of undocumented migrants. And then some cities are starting vaccination at accommodation centers for homeless people where ID might not be a condition for access, but this is not yet reality. Munich plans to enable undocumented migrants to get vaccinated without ID, and in Bonn and in other cities, sometimes unofficial agreements have been made between voluntary service providers for undocumented migrants and health authorities to provide an eligibility certificate for these people. So as a summary of the challenges, of course, there's the legal entitlement and the protection against reporting, which has to be solved. But then also there is a practical implementation and the capacities of service providers, which needs to be ensured, because even if there is a legal entitlement, it's not much use if the security guard in front of the vaccination center will ask for an ID. And then the third big step is adequate information and building of trust among undocumented migrants because of the long history of the duty to report. And Overall, there's also the question, are we going for local solutions based on engaged individuals and organizations, sometimes with unofficial deals between health authorities and these organizations, or are we going for the recognition of entitlement, which would be of use beyond the COVID-19 pandemic? So what are potential ways forward? As soon as the GP offices get vaccines, clinics for people without health insurance could potentially vaccinate their patients, especially if we have a single dose vaccine. The disadvantage is that only a limited number of people can be reached and informed, and many clinics do not have the extra capacities to really vaccinate on a broad scale. And they are not included in the regular system, but they are separate. Then the second option would be to that clinics for uninsured and so-called clearinghouses for people without health insurance, which exist in some cities, could give out eligibility certificates, which can then be used in official vaccination centers or at GP offices. That would mean more inclusion in the regular system, but would of course mean a certain visibility for undocumented migrants and no guarantee for protection. And of course, another way forward is advocacy, continuing with advocacy for access to healthcare for undocumented migrants, including access to vaccination. Thank you very much for your attention.
Brilliant. Thank you so much, Johanna, and Gold Star for keeping in the time. And I mean, I think it's quite a remarkable thing to imagine that potentially upwards of 500,000 people could be excluded from Germany's vaccination program, which is the upper end of the estimate that you shared. So that's really quite, in and of itself, striking. And also very important and interesting to hear your point about the ambiguities about the national level, the federal level realities of how inclusive it is, but also about just the differences from municipality to municipality. On the one hand, this is positive because we have examples like Munich that are being quite inclusive, but it also means it's a bit of a lottery as to who gets access to the vaccine. So very important that you've pointed out that, you know, one of the solutions is really addressing the fundamental issue of the Residence Act requirements that undocumented people be reported for use of services. And this is really a structural change that's needed. So thanks again. Now we're very fortunate to hear from, I should have said at the outset, we have a wonderful panel. Please stick with us right to the end because you'll have a chance at the end of the panel to have a Q&A with our panelists. So, and in the meantime, you're most welcome to put your questions in the comments box. So now we're turning to Frank van Biervliet. Very happy to have you, Frank. Frank is policy officer at Bruce Help, which is a new regional public service, newly established just a couple of years ago, that works with Brussels people living in homelessness and sectors connected to that, so related to social, mental health, drug health care, child support services, and so on. So really looking forward to your presentation, Frank, especially since I think you're going to tell us about some examples of promising initiatives in Belgium, and in particular in the Brussels context, to really have a strategy that can reach all residents regardless of status. Over to you.
Thanks, Alina. Thanks to the members of the M8 Alliance. I'm really honored to be with you this afternoon. My name is Frank van Biervliet. I'm a nurse and anthropologist by training. As Alina said, I started working about a year ago at a new regional public service support service towards the Brussels homeless care sector. I will go rapidly through my slides. You will get them at the end. I've been asked to elaborate a public vaccination strategy for homeless people, but this is immediately mixed with issues about undocumented migrants. Let me give you an overview of, this is an example of an ethos typology. Ethos is a tool made by the European Federation of Associations working with homeless with the homeless. And so we use this international typology of housing exclusion, applying it to Brussels. We did that because we tried to count the number of homeless people, which is when you want to plan something like a vaccination strategy, for instance, as a public health authority. This is really crucial. I had to cut the screen in half, but here you see some situations of housing exclusion that really concern many undocumented migrants, and we don't have slightest clue actually about the number of people undocumented living in overcrowded housing, in unfit housing, in under threat of eviction. So the Brussels city count that we did really reflects homeless people. I think at least a third, if not half of all these people are also undocumented. So we see that undocumented migrants face much harsher housing exclusion than compared to the rest of the population that we counted. I will come back to numbers later. First, some good news. As Michelle already highlighted, the importance of adapted health promotion tools. We've had a very resilient civil society in Brussels and also for regional governments, actually. So here you see some examples in many languages, videos, everything that you'd like. Other good news is that both the federal Belgian government and the Brussels region have really took some protective measures that were very inclusive towards undocumented migrants. Sorry, inclusive testing strategies, outreach teams. There's also a place in Brussels where you can stay if you test positive for COVID or you have symptoms. All these programs are also available towards undocumented migrants, less so for something that goes beyond emergency accommodation. So this is a big advocacy point of Brussels civil society. And up to now, there's a moratorium on eviction that also includes occupations of undocumented migrants. Some have even been encouraged by governments, by the Brussels government. This contains benefits and risks, but I don't have time to come back to go deeply into that. So in practice, there's a firewall principle in place for all these programs, but it lacks a bit of legal clarification, honestly. So to come to the point of vaccination, basically two main strategies in Brussels. The one is to allow people to go to the regular vaccination centers. On the right, you see in French an overview of the 10 vaccination centers that are currently are open or are being opened. Obviously, when I told you about 5,300 homeless people, in reality, the number of long-term residents, I think that there is no recent scientific estimation. There are up to 60 to 80,000 people in Brussels. So one way to get as many needles in as many arms is to invite medical card holders. In Belgium, undocumented migrants can access healthcare. They have to contact their local social welfare center for that. And then they can get a health card that right now is renewable every 3 months. The idea would be for social welfare centers to invite medical card holders. In French, this is called aide médicale urgente, AMU. This is the AMU sign that you see. But the problem is, I just consulted last year's data. There are only about 13,500 medical card holders in Brussels. So clearly there's a gap. There's clear political will from both the regional and federal government to get every resident in Belgium vaccinated, whether you are undocumented or not. But how are we going to do that? One way would be for GPs to push priority vaccination in, for instance, undocumented people who have HIV, schizophrenia, etc. But they could also push vaccination at the same time as for general population in Brussels. There are still some issues to be dealt with. Sorry, like as raised by my German colleague. the identity check at a vaccination center. We still need to build a communication strategy with all of civil society working with migrants. We need to multiply reservation procedures to make it low threshold, and there are still some legal clarifications to be had, but there is goodwill to make sure that this will be possible. There will also be a much lower threshold intervention mobile outreach that is under construction. 4 partners are humanitarian partners are currently thinking about a program, people with medical health promotion and logistical expertise. The idea would be to use a single dose vaccine, which will be available in Belgium by the 3rd week of April. So we'll be able to start at that point. Major questions still unanswered about data collection, for instance, because the idea would be to offer a paper vaccination booklet in places where with a lot of housing exclusion. In priority, this would be, you know, squats, occupied buildings, emergency shelters with a high turnover. But we can also, in the future, you know, work with, I don't know, a sex worker association, the Brazilian Pentecostal Church in Brussels, or the Polish community. We could really do some great public health work with this kind of mobile team. But the link is we have a lot of freedom to determine the terms of reference, but we still need to, you know, ideally we would propose multiple schemes where either a person can get a paper vaccination booklet, but what if the person gets a residence permit later on and wants to travel across the EU? Should we also allow electronic proof of vaccination? We're still working this out with the FIRE principle in mind, really. That's it for me. This is my last slide. On the right, you see a cartoon that was made during a European Gastein conference a couple of years ago, where we had a debate with WHO about advantages and disadvantages about how to make public health data more visible, because this is still not the case for Belgium. Without seeing Michelle's presentation spontaneously, you know, some of the feedback that I get sometimes is, oh, you know, if does getting tested or getting vaccinated will imply expulsion rather back to Belgium from the UK or under the Dublin Agreement? The answer obviously is no. Nobody wants that, but we still need to clarify things legally and then communicate this, this clarification. There are only collaboration agreements between regions and federally. This is not enough. Another point really is that what the Brussels City Count has taught us in the last couple of months, we really fear, as researchers actually, a massive general shockwave of poverty, housing exclusion, and overall public health degradation that will really also harm undocumented migrants' living situations, despite all the protective measures. That's it for me.
Thank you, Frank. That's a very evocative term you've just used, a massive shockwave of poverty. And I think you've really, really helpfully made the links in your presentation, you know, between the public health crisis that we're facing and the related concerns about poverty, destitution, and really the extraordinarily concerning economic impacts of this pandemic, especially on people already living in situations of precarity. So thanks very much for bringing in those elements. It is, on the other hand, really, really encouraging to hear the goodwill, the political goodwill in the Belgian context. Very refreshing. We heard from Michelle some other examples of countries that have at least stated their intention, but you've gone further to show really the actions of the authorities in Belgium to really take steps. Notwithstanding practical barriers continuing to exist, including ongoing challenges in accessing the AMU. But anyway, thank you so much for that. Now we're going to turn to hear about the situation in France, which is another country where there is a federal scheme in place, the AME, to at least in principle grant access to healthcare for undocumented people. We're very fortunate to have representatives from the French National Institute of Public Health. So happy to welcome you, Stéphanie and Jalpa. Jalpa Shah is the project lead for vulnerable populations at the French National Institute of Public Health. And during the early months of the pandemic, she's been working to reinforce a new program at the Institute aimed at strengthening equitable health solutions for these populations. So brilliant to have you, Jalpa. She'll be doing the presentation today, but her colleague, who is the coordinator of the Health Equities Program at the Institute, will be with us as well, in particular for the Q&A. Part later on. So over to you, Jalpa.
Thank you so much, Lena, for that wonderful presentation. And thank you to the M8 Alliance for inviting my colleague, Dr. Stephanie Van den Toorn, and myself for this presentation. I'm going to go ahead and share my screen with everyone. That should be showing now. So today I'm going to be, as Elena mentioned, presenting how at the French National Public Health Agency, we're currently developing an evidence-based COVID-19 vaccination strategy for hard-to-reach populations in France. So really briefly, just to give everyone a bit of an overview of our current vaccination schedule in France, it's a 5-phase schedule with priority based on age, so older age, profession, and then having a high individual visits of vaccination. And so this means that individuals living in precarious conditions, so undocumented migrants and refugees will actually be prioritized in phase 4, which is for this summer. So in France, as in other countries across the world, a large proportion of undocumented migrants and refugees are actually found amongst people experiencing homelessness. This includes people living on the street, living in temporary housing centers, and then in shanty towns or ghettos. In Paris, for example, more than half of people experiencing homelessness are actually migrants. So our objective at the French National Public Health Agency is to not only identify key factors and interactions amongst those factors that impact COVID-19 vaccination amongst such hard-to-reach populations, but to adapt our vaccination strategy in real time to take these into account. So this involves kind of 3 steps that we'll be following. First off, we've already gone ahead and constructed an initial model for vaccination based on behavior change theories and then results from 3 different scoping reviews. Our next step is going to be adapting our COVID-19 vaccination strategy based on survey findings with hard-to-reach populations and structural equation modeling at 2 different time points, as well as one-on-one interviews with hard-to-reach populations and key stakeholders that work with them. And then finally, we'll be sharing our findings via, first of all, our multi-stakeholder transfer of knowledge webinar series that we actually started last November, MOBCO, that specifically looks at COVID-19 and hard-to-reach populations. So in terms of this scoping review that I'll be presenting today, that's specifically on evidence-based vaccination strategies for hard-to-reach populations. I'm not going to go into too much of the details of the methods. I've kind of presented it on this slide, but we did the actual review search on January 15th this year. In terms of keywords and mesh terms, I think it's important to keep in mind that we broadly searched hard-to-reach populations. So that included refugees, migrants, but also underserved populations, substance users, sex workers, and so forth. In terms of vaccination, we were interested in all vaccines. We hadn't limited it to a specific vaccine. And then we were interested in evidence-based strategies. So for our study, we used the PRISMA extension for scoping review, and ultimately we found that we retained 16 sources in our final review of 531 articles and reports that were initially found. We had very strict inclusion and exclusion criteria. So just to recap, we were focused only on the evaluation of vaccination programs that targeted specifically hard-to-reach populations. And what we found actually was quite interesting, and it complements the other reviews that we've had that have been ongoing these past few months. But first off, there were a limited number of evidence-based studies on vaccination strategies that target hard-to-reach populations. And then when we try to ensure that they're also applicable to the French context, so universal healthcare, free vaccination, that further reduces the number of applicable studies. In terms of vaccination for hard-to-reach populations, structural factors tend to play a more consistent role, whereas individual factors such as age, gender, previous incarceration, drug use, and ethnicity, they tend to vary by disease and vaccine. And then what was especially interesting for us, and which is especially pertinent in this case to the COVID-19 crisis, is that factors tend to vary based on the outcome. So whether we're talking about a single dose vaccine or vaccine initiation for multiple dose vaccine versus vaccine completion, so when we have 2 or more doses. So when we look at vaccine initiation, there were a series of influencing factors that we observed in this particular review. At an individual level, awareness of the severity of the disease, concerns about getting the disease were key factors. Doctors' recommendations were associated with initiation of vaccination for pregnant women and diabetics. Having immediate availability of the vaccine in cases where there was screening, and having on-site vaccination after screening played a key role in was associated with initiation of vaccination. And then distance to vaccination clinic, as well as waiting time at the clinic, also played a role in vaccine initiation. And then finally, social mobilization, community engagement, and outreach programs were key in increasing vaccine uptake amongst hard-to-reach populations. So when we look at competing factors for vaccine initiation or taking a single dose vaccine, pressing material needs consistently out, such as food, water, and shelter, consistently outcompete preventative health measures, so vaccine uptake. Now, when we switch to vaccine completion, we have a different series of influencing factors that tend to come into play. So poor self-related health scores at the individual level, receiving screening results when there was a screening in place. So for example, for hepatitis C, having an accelerated vaccine schedule, so 2 months versus 6 months, again, for hepatitis B and C. Having nurse case management, so that was for a 6-month Hep A or Hep B vaccination, and then convenience, so the association of a vaccination clinic with other services, such as needle exchange services. And then finally, monetary incentives were a key player in vaccine completion, with a particular clinical study showing that monthly incentives were associated with vaccine completion, whereas weekly contact with an outreach worker were not. So when we talk about competing factors when it comes to vaccine completion, there were 2 key factors that are especially important when we think of hard-to-reach populations. So threats of eviction, so we're thinking of more shanty towns or campsites for gypsies in this case, and then actual eviction or expulsion, which makes it really hard to follow up with these populations, but which also play a role in outcompeting needs for preventative health services. So just to conclude, these findings in this particular scoping review have really put a couple of ethical considerations into play for us at the French National Public Health Agency. Are we going to be leaning more towards proposing single versus multiple dose vaccines for COVID-19 for hard-to-reach populations, recognizing that the Johnson & Johnson vaccine, which is single dose, will be available for phase 4 normally in terms of timing? Do we put in place mandatory screening prior to vaccination to determine current or previous infection, given ongoing vaccine shortages? Or do we just skip screening, given that evidence shows in France amongst people experiencing homelessness in the first wave of the pandemic last year, there was really high exposure and transmission. So do we just assume previous exposure and give them a single dose? Should we be prioritizing a specific vaccine for these populations, perhaps one that has higher efficacy in reducing transmission at a single dose? However, this is where we need to start considering, and this is where our qualitative studies will really come into play, because already we see that there are a number of factors that play into COVID-19 vaccine hesitancy for hard-to-reach populations. Things like vaccine brands, rumors about the efficacy of the different vaccines, the desire to have the same opportunities as the general population, and what is considered which is considered non-discriminatory then by certain populations, all come into play. And then just to conclude, we are thinking very strongly of, in terms of next steps, of looking into the experiences on COVID-19 vaccination of hard-to-reach populations at a national level. And we know that, for example, in Denmark, they integrated individuals experiencing homelessness in their vaccination strategy from the get-go. Israel has already started vaccinating for a couple of weeks now refugees across the country. So we're definitely interested in talking with other countries with national vaccination strategies for hard to reach populations. All right, I'll just finish off there then. Thank you.
Thanks so much, Jalpa. You covered an extraordinary amount of ground there in a very concise presentation. Thank you. And I mean, I guarantee that, well, I will, if nobody else asks in the Q&A, to hear more about your knowledge sharing plans and these webinars and how you've been including civil society actors and migrants in the evidence gathering phases of the work. So really interesting to hear about that. I thought it was very interesting and notable that you said there's the dearth of evidence, that you really took the time to do a search of PubMed and look at what the evidence base for this, and there seems to be really a dearth of published peer-reviewed evidence to really draw on. So it's very interesting and heartening to hear that you're open to exchanging on practice with different countries, maybe also with Belgium, since it seems they have a lot to maybe share in terms of their experience. Great to hear that Denmark is having an inclusive approach. In our experience, undocumented people really struggle to access healthcare there, so it would be interesting to see how they're taking them into account. And finally, I thought it was really interesting your point about competing factors, which include food, water, and shelter. So, I mean, not only does homelessness, housing insecurity, and poverty create obstacles and challenges to reaching people with the vaccine, but it actually makes it hard for people to prioritize getting the vaccine as well. So addressing poverty, addressing housing exclusion, we heard from Frank about the possibility at least of temporary shelters. That's also maybe an important part of thinking through what we need to include in vaccination approaches. So now we're very fortunate to move to another part of the world and hear about the situation in South Africa. We are thrilled to have Joe Veary with us. Great to see you. Joe Veary has a background in public health and interdisciplinary research, looking at the intersections of migration and health. She's associate professor and director of the African Center for Migration and Society at Wits University, where she coordinates the Migration and Health Project for Southern Africa. She also directs the African Research University's Alliance Centers of Excellence on Migration and Mobility. Very impressive experience and insight on these issues. We look forward to hearing from you, Joe, about what you've been seeing about the South African context.
Thank you. Thank you so much. Are you able to see my slides okay?
Yes, we can see your slides, Joe.
Okay, brilliant. Thanks so much. So before I begin, obviously, many thanks to the organizers, not only for the invitation, but also for focusing on such important issues during these very difficult times. So I'm going to be talking to you about the South African experience and the challenges that are currently faced, with some suggestions for what we might want to think about, particularly in terms of learning from other contexts. As I'm sure that many of you are aware, one of our biggest challenges is that we don't actually have a vaccination program underway. We do have a very small supply of vaccines, which are being provided to frontline healthcare workers correctly, and they're not enough to vaccinate healthcare workers. We have much secrecy and confusion around what the plan moving forward is in terms of accessing vaccinations. You may have heard that South Africa recently sold back or sold to COVAX, and I think via the AU program, the African Union program, 1 million doses of AstraZeneca that we had in the country. And we really do face this huge crisis around what's happening. Issues of vaccine nationalism, vaccine apartheid are playing out at the global level. Much research, participation in global, in clinical trials and so forth taking place in the South African context. And the reason I'm emphasizing this is twofold. One, not only is this unjust in the context of everybody within South Africa and requires much greater global advocacy and work, But secondly, my concern is that we may run the risk of our own version of vaccine nationalism within South Africa when our vaccine program, let's use the affirming when, gets underway. I don't have time today to go through these various issues, and I'm aware that many on the call are less familiar with the context that I'm speaking to. So I just wanted to very briefly go over these 6 key points. Firstly, South Africa and the region is associated with diverse population movements, including people moving within countries. South Africa itself is home to much internal migration. And the reason I mention this is that in terms of thinking about ways to better engage the conversation around ensuring undocumented migrants and other non-citizens are included in our vaccination program, is to talk to what I call here, as you'll see at the bottom, migration aware and mobility competent healthcare system responses. Because what we see is the South African public healthcare system is unable to manage the movement of citizens, let alone non-citizens and undocumented migrants. So we are already in a big challenge where the very prevalent movement of people is not actually reflected in the way our healthcare systems are designed. Around that and the reliance on a failing and struggling public healthcare system, access to basic services, to documentation is incredibly difficult for undocumented migrants in particular. By undocumented, I'm referring to individuals who are currently without the valid documents required to be in the country legally. And I want to emphasize that because in many cases in our context, it's assumed that people who are undocumented have crossed the border in an irregular way. That's true for some, but the ways in which individuals struggle to renew permits, renew documents, apply for asylum in the context of South Africa, the way that the systems surrounding those are inaccessible and unjust can render people undocumented. Linked to this is the way in which our policy, legislation, policy terrain is increasingly restrictive, both in terms of the management of people crossing borders. So here I'm talking about our Immigration Act as well as our Refugee Act. And it's the Immigration Act that governs individuals considered to be undocumented or, as far as the state's concerned, illegal aliens. And we are seeing how that form of approach to people who move across borders is increasing. We're seeing further restrictions in access to health, and all of these are conflating in the current moment around issues of COVID. This links to issues around the way in which the nation state sovereignty is taking over public health arguments, and linked to the various ways in which a global health security approach is increasingly used to justify restrictive immigration approaches. We see this globally, and it's not simply in the context of COVID. This has been a creep that we've seen in other moments. But what this means for undocumented migrants in particular is the way in which the trope of the undocumented migrant, the foreigner, the dangerous other, the infected person are mediated and motivated in popular discourse and amongst government officials. So this is the context before COVID, and in the context of COVID, one of the key conversations and questions that we're having at the moment is, why is it so hard to ensure a sort of public health 101 approach, a basic approach to what a response to COVID, and particularly in the context of vaccines, should be? And here what we're saying is, obviously, and I think other speakers have mentioned it, any effective response requires everyone to be involved. A vaccination program will fail as soon as you leave people behind. So this is about a public health argument, but we continue to face challenges in incorporating the particular needs of working with undocumented migrant communities. So why is this so hard? I would argue that it's because of the status quo that I've mentioned, plus. So it's what's happened before, and then it's the way in which COVID has been framed, has been positioned as ways to bring to the fore, on the one hand, some of the tensions and challenges already being faced by foreign nationals, including undocumented migrants, but it's also facilitated a particular space for a particular discourse to emerge. I have here our Minister of Health and our Minister of Home Affairs, formerly Minister of Health, himself a medical doctor. And there's a massive frustration about the fact that with two medical doctors who are responsible for the intersection between health and migration, that we are continuing to sit in a moment where individuals are rendered more vulnerable, are rendered more excluded because of various government interventions and exclusions. So what can we do? Well, obviously I'm not going into this. Many of you are going to be familiar with the images on the slide here, but I wanted to emphasize that we have some tools in our toolkit. I'm not suggesting that they are easy, quick fixes, but from universal health coverage through to various World Health Assembly resolutions, to the Global Compact for migration, for refugees, all of these come with particular key opportunities for arguing for the public health justifications for ensuring that we're including undocumented migrants in our response. Importantly, this is beyond the right to health. Of course, this is implicit, and of course, this is absolutely what should be driving all of the work all of us are involved in, and I'm sure that is the case. But we need to be making that public health argument strong and clear. In our context, there has been some notable action at the level of the African Commission, so at a continental level. But, you know, again, as always, these resolutions don't always hold much weight in terms of holding countries to account, but they do provide many opportunities for working to draw attention to various advocacy strategies. In the South African context, I've just put one slide here from the equivalent of what's the word called? I forget now, but you know, a common newspaper, and in this case, referring to illegal immigrants and referring to the fact that the state has agreed to provide these individuals with vaccinations. This is because at the beginning of February, the president has, after making various conflating and conflicting statements, indicated that we want to make the vaccine available to all. And we know that this is necessary for us to deal with addressing the COVID pandemic. But importantly, he also recognizes that for undocumented migrants, there are particular challenges. And like recognizing that this is going to have issues in terms of recording and tracking a vaccination history. But I want to focus importantly on and just reminding us that the language around illegality tends to be the lingua franca. I'm about to end. I know my time is coming to an end. I'm really glad that we have colleagues from PICUM here. I want to pick your brains about ways in which we can mobilize implementation of formal firewalls within our response. We know that there are many concerns amongst individuals who are undocumented about engaging with the healthcare sector in various ways. We also know that there are some good practice examples of where there have been successes in using firewalls. And importantly, it was mentioned, I think in the presentation linked to France, about what this might mean in the short term. What do we need to do to get this implemented in a way that will ensure everybody is safe? So to finish and come to a close here, I think we do also need to look at COVID in the context of undocumented migrants as whether or not it provides an opportunity. Is it providing an unwelcome opportunity in some ways, through the pandemic, to really bring to the fore the reasons and justifications for why we can't leave anyone behind in our responses to health? We know that an effective response is about public health programming. It's about the basis of including everybody, ensuring everybody's involved. This isn't only about a state response, but it's also around global responses. It's about ensuring that equity and access to vaccines is present and that vaccine nationalism is addressed at the global level, vaccine apartheid is addressed at the global level, as well as ensuring we don't engage in vaccine nationalism at the level of the state. We need to advocate for migration-aware interventions, and this is particularly essential when we're talking about regions and countries of high movement, high population mobility. If there's a 2-dose vaccine, what happens in terms of where an individual would have to access a second dose, and what does this mean for solidarity in other contexts? Securitized responses risk undermining efforts to address the needs of undocumented migrants in the context of COVID. And finally, we do need to think about moving forward, and the language of what vaccine passports or vaccine certificates mean in terms of surveillance, in terms of detention, deportation, in terms of issues around the effectiveness of firewalls. Thank you very much, and apologies for going over time. Thank you.
You did great, Joe, in terms of the time, so no worries. Yeah, thank you very much for reminding us about the vaccine equity issue as the global issue as well. I mean, the same argument goes that even if Europe fully vaccinates all of the residents in Europe, but there are parts of the world that remain unvaccinated, this pandemic is not under control. So we really need to understand global equity dimensions of this issue as well. Also, not only around public health, but just around fairness, as Michelle was saying earlier, and just the right thing to do. I think you've very forcefully shown how increasingly restrictive immigration enforcement measures really can be at odds with our public health priorities. And even in the headline that you shared, that illegal migrants will not be denied the vaccine, on the one hand, a statement of inclusion using the language of exclusion and dehumanization. So, I mean, these things really are at odds with each other. And so we do, again, need to come back to that background context is really an important factor here. And as you said, people, struggling to renew permits, to regularize their status, that this has implications also in terms of the pandemic. And your point also about health security arguments, public health in a sense, security arguments being used to actually implement more draconian immigration policies. So thanks very much for bringing that context and for giving us insights on the situation in South Africa. I'm sure we'll have some questions for you in the Q&A. We'll turn now to our last speaker, by no means least. Very, very happy to introduce Jessica Merone, who is going to share with us the example of the United States. So Jessica is a PhD candidate in International Joint Program on Human Rights, Society, and Multi-Level Governance at the University of Padova in Italy. Her dissertation focuses on undocumented migrant women and their experiences in the context of accessing sexual and reproductive health care in the United States and in Italy. And we really look forward to hearing your insights, Jessica, on the situation for undocumented people in the United States.
Thank you, Elena, for the introduction. Good evening, everyone. It's a pleasure to be here with you. As Elena discussed, my name is Jessica Merone. I'm a PhD candidate at the University of Padova in Italy. And my presentation is regarding barriers undocumented migrants face when accessing the COVID-19 vaccine in the United States. This is just an overview of my table of contents. I wanted to begin my presentation regarding the terminology that I would use for this presentation. Depending on the context that has been used, immigration and migrant has had different meanings and different connotations. I wanted to address that I'll be using the definition from the United States regarding undocumented immigrants, which are individuals who have entered in the country without authorizations and individuals who have entered the country lawfully and stayed in after their visa or status has expired. This does not include refugees or asylum seekers. And this in the United States is the preferred language to be used, not just not using the word illegal, but also alien. As you can see on my slide, in the United States, there are about 10.5 million undocumented immigrants. And the top countries of birth include Mexico, El Salvador, Guatemala, India, and Honduras. I also wanted to explain a little bit the healthcare system in the United States. It is a very complex, complicated system. So I just wanted to touch base on some information I thought would be useful for this presentation. The United States is the only industrialized country that does not have universal healthcare. Instead, we have something that's referred to as a public-private hybrid system. So mostly people who do have insurance in the United States, they have insurance through their employer. And then the second group of people who have insurance through public health coverage, which includes Medicaid, Medicare, and the Children's Health Insurance Program, also referred to as CHIP. So Medicaid is for seniors above 65 years old, even those who have certain types of disabilities. Medicare is for those who are considered some poor or near poor. And then CHIP are for students, CHIP is for children under the age of 19 who don't qualify for Medicare. And then there's a huge group of people in the United States, including citizens that are uninsured. We also have the Affordable Care Act, also referred as to Obamacare, which is the comprehensive healthcare reform, and it was passed in 2010 by former President Barack Obama. In regards to undocumented immigrants, as of now, Biden said that he is planning on changing this, but as of now, undocumented immigrants are not eligible to enroll in Medicaid or CHIP, and they're unable to purchase coverage through the ACA marketplace. But we do have a law that was passed by Congress called EMTALA that requires Medicare participating hospitals with emergency departments that if someone does come with an emergency situation, they cannot be denied access to healthcare access, regardless to their inability to pay or their immigration status. Additionally, undocumented immigrants also go to community health centers and also charity hospitals. Additionally, there are some states that provide state-funded programs for them, specifically regarding migrant children and women who are pregnant. I just wanted to explain a little bit the vaccination campaign in the United States. The US has bought enough coronavirus vaccines for 3 times the adult population. What has been bought and approved is Moderna, Pfizer, and Johnson & Johnson. I also want to state that President Joe Biden on February 26th stated, I want to make sure that they are all able to get vaccinated, and so they are protected from COVID without the ICE or anyone else interfering. They should not be arrested for showing up to be able to get the vaccine. ICE, as stated before by Michelle, is Immigration Customs Enforcement. They have an office where they arrest, detain, and deport undocumented immigrants. You can see by Biden's speech, his administration does prioritizes underserved communities, which does include undocumented immigrants. I also just wanted to discuss the federal recommendation guidelines from the Center for Disease Control and Prevention, the CDC, regarding which certain groups should receive the vaccine first. As you can see, phase 1A includes healthcare personnel. Phase 1B includes people of age 75 and non-health essential workers. And phase 1C recommends people between the ages of 16 and 64 with high-risk medical conditions, and additionally, essential workers that weren't vaccinated during the previous phase in 1B. And this is extremely important because undocumented immigrants are essential workers. They work in construction, they work in restaurants, they work in the farms. So they fit the criteria of the initial phases. I do also want to mention that despite this being a federal recommendation, states do have the right to make their own decisions on how to prioritize which group gets the vaccines first. There have been some states that have prioritized immigrants as part of the vaccine efforts. As you can see here, they include Arizona, Virginia, New Jersey, Oregon, Washington. Fortunately, I don't have time to talk about each state, but it's important to note there's also some states have done the opposite. For example, in Nebraska, the governor has said that citizens and legal residents come first and undocumented immigrants will come last. This slide talks about the potential barriers to the COVID vaccine that immigrants face. I think one of the big challenges is there are heightened concerns about the potential side effects. I think in general, as a population, we are all worried about how we will feel after getting the vaccine. And it's important to be mindful that, as I said previously, this population are more likely to be uninsured in the United States. And additionally, they work in job sectors that they're not provided health insurance. So they are not offered paid sick leaves. So if they spend 1 or 2 days sick, they're worried about not being able to go to work, so they won't income. And additionally, health costs, the cost that they have to seek healthcare for the side effects that they experience. Another major barrier is data collection. This has been talked about by previous presentations before me. What's collected is name, address, state of birth, ID, and then also what the CDC also requires states to submit this data, so then it can monitor who is getting the vaccine and who is not. So this is a big concern for this population. Other barriers include limited transportation options. Many undocumented immigrants aren't allowed to have a driver's license, so many use public transportation. Additionally, childcare, lack of flexibility with work hours, language, literacy challenges, technology barriers. Additionally, another major concern is that they don't know that they have access to the vaccine. There's just all this misinformation. Lack of access to information. Additionally, during the Trump administration, Trump's administration immigration policies were based on zero tolerance of undocumented immigrants. And there was this concept called the public charge rule that was established in 1882, which allowed the US federal government to deny people a visa who were likely to become a public charge. What does that mean, public charge? That means a burden on the social welfare system. In 2019, Trump expanded that definition and that criteria and added other social programs into it. So that made undocumented immigrants more likely to avoid public programs because they fear that would jeopardize their immigration status in the future. I'll just skip this slide because I'm running out of time and just focus on the policy recommendations. I think one of the most important ones is to make available the locations, not just easy access. For example, as mentioned previously, a lot of the undocumented immigrants aren't able to drive, so make the locations not only drive-through, but also be like walk-up. And then also make them accessible with their work hours, so early morning, evenings, on the weekends. Additionally, one of the big policy recommendations is to build trust and empowerment in this community. So take the providers who already work with this population and put them in these vaccination administration sites, and so they can see that they have a familiar face, that there's a trust that can be that can be built. Additionally, target outreach and education efforts, especially informing them that they're able to get the vaccine and there's no cost. Minimizing the collection of personal identification information. Additionally, there's this confusion between the federal, state, and local level, how the vaccines are administered and how undocumented immigrants, where they're included in the phases. So there's clarification, there needs to be clarification on that. And additionally, also prioritizing undocumented immigrants who are in the detention center. I just wanted to conclude my presentation with, this is a quote that was mentioned before as well from the Department of Homeland Security that said that it is a moral and public health imperative to ensure that all individuals residing in the United States have access to the vaccine. There's this this person that's wearing a sign that says immigrant rights are human rights. And I wanted to conclude my presentation with a quote that I found that said, however inclusive Biden's statements are, there are empty gestures if barriers to accessing the vaccine are not specifically addressed. Thank you.
Thank you so much, Jessica. That's a very helpful overview of the situation in the United States, both in terms of President Biden's commitments, what might be available under national law, but also the concerns that remain present. So thank you again to all of our panelists, and thank you to our participants who've stayed with us. We now have about 30 minutes for a Q&A. And we've actually already had a few questions that have been posed to the panelists. So I've been doing my best to gather them. So I'm going to suggest actually that the first question go to our colleagues from the French Institutes of Health, National Institutes of Health. I see, Stéphanie, that you already partially responded to one of the questions. And that question is, how did the French authorities foresee working with civil society partners in terms of actually doing the work of delivering the vaccine? And maybe at the same time, you can comment on a little bit more on the plans around the knowledge sharing that were mentioned in the presentation. And finally, there's a second question I was also going to put to the colleagues from the French Institutes of Health, just to kick us off, but others can feel free to weigh in afterwards. One colleague has asked, in the absence of reliable data, how do we prepare these rollouts? So maybe you can just share your sense of that. And others on the panel are welcome to also join in for that one. But if you can first comment, either of you from the French side on engagement with civil society.
Okay, thank you, Alina, for the question. In fact, we planned to have a seminar to share knowledge, and we have an interview with all of the association. That's mean Doctor of the World, Medicine Without Frontiers, Red Cross, and all the association could be involved in this plan. So I sent to Laura that all Secours Catholique, also every association is welcome where they are on the field, because the aim of the transfer the knowledge, the scoping review that Jalpa has shared to us with the best evidence-based knowledge to be effective on the field. For the second question, we plan to do quantitative studies to estimate the vaccination coverage on homeless people, gypsies, including migrants, including undocumented migrants, of course. And we plan to do that in different cities, in Marseille, in the south of France, in Paris, and in the north of France, in Lille, with the Grand Sainte, which is, yeah, so I know, Frank, that I think you know that because it's next to your country. So we plan to do that with we've also to identify the different determinants which will improve the vaccination, or which will be some difficulties to the vaccination, to adapt the strategies plan during the summer. So we plan the studies on June, and maybe a second wave in September, October, depending on the financial support.
Thank you so much, Stéphanie. Do any of the other panelists want to comment on how to really build out a vaccine rollout, and with in absence, what seems to be an absence of really empirical data to really guide this? Where to look for examples of practice? Frank, please.
Yeah, I wanted to comment first on the term hard to reach populations, which is a term personally I don't like that much. Everyone I spoke to some years back at ECDC, when they heard me, said, "Oh yeah, you're right. We see what you mean." You know, hard to reach people can also be the deaf, the isolated, people in poverty, whatever. When we say hard to reach people, we need to explain that it's hard to reach from the current public health system in place, and this is a top-down public health approach. So how to how to mobilize civil society, I think. Well, it's including them in sessions to discuss how to roll out the program. Maybe also try to include the people concerned themselves, but for me in Brussels, this is very difficult as well, because things have to go quickly, and this takes time to build with local actors who know the fields in order to organize sessions. Some have been held in Brussels. I wanted to say also generally that I feel like I miss something in terms of research on health literacy. When I was a first line worker myself with people, I read stuff in the chat like, you know, we should do outreach programs for everyone. Obviously, for some part of the population, this is very cost effective, but we should also think about the general objective of vaccination is to get herd immunity, and this will also decrease the exposure towards undocumented migrants, for instance. So in terms of cost effectiveness of programs, we shouldn't put all our money on hard to reach people in order to make sure that every person living alone in a city would be vaccinated. You have to find quick wins on both sides of the spectrum. But something else is sorry, just to finish, is something really important is so I think the despite low levels of health literacy is also the resilience of undocumented migrants, and the necessity to empower people, and this has to go through some spending of some public health program that offers basic information, obviously.
First, I think you're right, Frank. I'm sorry for the term of hard to reach. It's just an epidemiologic term to a methodologic one. But you're right. And moreover, when you reach this population, they are very easy to reach, in fact, because they are very happy to be, if you have the confidence and so on. So yeah, I think you're right. I don't know if Jacques, you want to answer next question.
Yeah, absolutely. So I completely agree with you, Frank, as well. In the literature in general, there isn't a consensus at all, obviously, as you must know, on which term to use. Some people prefer hard to vaccinate, but that brings into question more logistic issues. I agree that, yeah, hard to reach is probably not the best term to use. I'm not really sure how we would translate it from French, but we do tend to focus more on living in precarious conditions as a better term to use. And then in terms of, I just wanted to, I definitely agree with you on what you're saying with respect to literacy and health literacy, but also digital literacy, which has a huge impact during COVID-19. And while that didn't come up in the present review that I talked about today, when we looked more at access to healthcare for vulnerable populations or populations living in precarious conditions, that was definitely a key factor. So it doesn't come up with the specific inclusion and exclusion criteria I used for this review, but it's definitely something that needs to be taken into consideration.
Johanna, please go ahead.
Maybe on the issue of what role does civil society play in reaching undocumented migrants. We are, of course, always in this ambivalent situation that on the one hand, we see these people and we have access, and on the other hand, we do not want to be a systematic well, we don't want the system to rely on us as a humanitarian organization. We go in where there are gaps, but then we come out again and highlight the gaps and try to convince the regular system that there is a gap. And so this, we always have this, but of course it's especially ambivalent in the case of vaccines, where we have an urgent need for, a quick response and a completely overwhelmed health system as well. So we try to, make clear that we do something, and at the same time, we do not think it is correct that we do it, but that the health system should take care of these issues. So it's definitely ambivalent, but I think civil society plays a big role because access is there and trust is there. And so we probably need to cooperate. And as I said before, there are already a number of basically deals between health authorities and civil, like voluntary organizations, sometimes very small, in different cities in Germany. And this will work for a while, but we at the same time have to work for more sustainable solutions as well.
I think you've answered one of the questions actually that was asked, Johanna. One of the colleagues, I think from Switzerland on the call, had said, shouldn't we just maybe leave it to NGOs to do the implementation? But I think you've given some insight on why that's maybe, it's really important to work closely with civil society, but maybe not really desirable on many levels to leave that work to them, either in the context of the vaccine or more generally, having this kind of parallel arrangement. So that's very helpful. I see, Joe, you have your hand up. Please go ahead.
Thanks so much. Just to sort of add to I think the question there about what do we do in the context where there's limited to no evidence to sort of inform responses. I mean, I think we have to be careful in assuming there is no evidence, right? Sure, there's no evidence around COVID and this moment in time, but there are many lessons learned, whether we're thinking about HIV and we're thinking about the forms of rollout that needed to take place, the forms of engagement, the forms of access, the forms around trust and these sorts of things. And I think that in the South African context, that's been one of the real frustrations, is acknowledging that within South Africa, we sit with a wealth of knowledge about what has and hasn't worked in the past around issues of trust and access, including hard-fought battles to ensure undocumented migrants have access to HIV, TB testing, treatment, etc. So there's been a real frustration that that's been separated. And I think that's where this issue around the role of civil society comes in. Again, when we think about our HIV response, I'm not for a second saying it's perfect, right? But one of the lessons over, the last 2 decades has been the importance of ensuring civil society is engaged and that different constituencies are represented and moving away from the hard to reach or key populations language. But the ways in which I think this is mirrored in many contexts, the ways in which national sort of advisory committees around COVID have been established, is they haven't brought in that experience. And so many have become very technical. They are very, sort of applied, which, in terms of the science. And I'm not suggesting that's wrong in terms of we need those components, but without the kind of links to people and communities and rollout, we're making mistakes. And we've seen that whether we're looking at the UK with now having vaccinated sort of, a good proportion of its population, but also in the context like we're at, where we don't even have a vaccine. So that was just to my second point, which is without a vaccine in place, we could argue that South Africa, and there are other countries in a similar situation, are at a good moment to be mobilizing for what a response that is inclusive should look like, right? So there is, on the one hand, this opportunity to, how do we get on the, the table, at the table with people? But the thing is, because everybody is so concerned about access to a vaccine in the first place, bringing in conversations around the need of people who are considered to not be citizens creates tensions that we're aware could do more harm than good. And this was something I wanted to raise around sort of, the push for civil society engage, to take on a role, or how advocacy campaigns should work. I think we're also all aware, I mean, again, maybe it's not in every context, but there is a concern that a very active and organized migrant rights sector can sometimes be more vocal in our context than some of the more collective approaches, for example, around the right to health, let's say, or vaccine access. So you suddenly have a very, very loud voice that is reflecting a much, much smaller population. And what this can do is it can inadvertently support the government's suggestion that there are many more undocumented or foreign nationals in the country than there are. I don't know if I'm making sense, but there's something about how do you develop a coalition to ensure that vaccine access for all, rather than having a parallel campaign for undocumented migrants, for refugees, for asylum seekers, for sex workers, etc. And this is another tension and challenge. And just finally, and obviously I'll stop now, but is really, also the issue of how do we work with frontline providers? There's often an assumption they want to be also providing services to undocumented migrants, and that this is more of a systemic sort of structural issue. In South Africa, and I know it's in other contexts too, there is real reluctance and real pressure at the level of the provider, the receptionist, the clerk, the security guard at the clinic, to keep the foreign national out. So it's not simply about implementing existing protective legal frameworks. It's about how do we do that work at the level of facilities to ensure that the policies and legislation that exist are implemented. Thanks.
That's a great reminder, Jo, that there may be very limited evidence in terms of vaccine distribution and so on and so forth, but there's maybe a lot to learn from previous experience with TB, HIV, and so on. So we really need to harness those hard-fought lessons from, as you say, decades-old lessons to apply to this new context. So I think that's a great reminder. And mobilization. It was nice to hear also that the French foresee that as part of their strategy. Speaking of whom, Jalpa, you wanted to come in?
Yeah, it's just something we've observed previously in France with the measles outbreak back in 2008, which kind of raged across France amongst populations living in precarious conditions, specifically in gypsy camps and Roma groups. And there was a real conflict in a certain sense between objectives for NGOs, for associations working in the field, and then security forces. And we're coming back to this idea of threats of being evicted and then actual evictions, despite the need for multiple doses of a vaccine. So that's definitely an issue. And what's really interesting, and Stephanie can definitely speak to this more, but in our very first webinar of this transfer of knowledge that we're trying to really initiate between field workers and government agencies, is that even for screening people for COVID-19, especially amongst people experiencing homelessness, it was the same issue. There was an encampment right outside Paris that was evicted the day before our webinar, and it was definitely something that came up a lot from actors in the field.
Johanna, please. Or did you finish, Shilpa? Yes, Johanna, please.
Yes, thank you. Maybe one other issue that Joe also mentioned, the question, should we go, continue with the argument of the human right to access healthcare and universal health coverage, or should we make stronger the argument that is also true of the public health benefits of vaccinating everybody? And I mean, there's as is with the first line health care providers, there's of course the issue of racism in there, which the public health argument could also be inverted. At least in Germany, we are very worried about using the argument of this, vaccinating undocumented migrant will bring a major public health effect, because it can be turned around in, seeing them as a potential threat to public health, and that is, can backfire in some way. So we try to keep it with the human right to access healthcare, because we are a bit afraid of using the other argument, and also because we want to, of course, have legal changes that are not restricted to the pandemic situation, but last beyond that. Because of course there is the idea to make exceptions for the pandemic context, but then have restrictions again afterwards, and we would like to avoid that. And then another point is that I really think that these three challenges have to be all be addressed, like the legal situation, of course, like the entitlement, but then also the capacities, training, sensitization of the health workforce, but also of security guards in front of the vaccination centers. And then thirdly, awareness raising, health literacy, trust building among undocumented migrants. And I think we have to work on all three levels to get access to vaccinations.
Thanks very much, Johanna. I wanted to just briefly come back to Joe's point earlier about coalition building. And I mean, I think it's a really, really good point, especially in a context of relative scarcity, even here in Europe, that there is this concern that, the ask is for putting migrants ahead of other people, or potentially making the case without making the links with others who face barriers. So I think it is really important that we've all been talking today about inclusion and equity, that where there is a rollout, that we need to have people included and not excluded based on status. So, but I think your point is very important, Joe, about coalitions, and some of the barriers faced by undocumented people are very much linked to being undocumented, and criminalization of their status and so on and so forth. But there are many barriers that are shared by others, sex workers, people living in homelessness. We've already heard about a lot of those overlaps today, and we need to be understanding and articulating how this is a shared issue and a shared need. So I think that's a great point. There is a question, and I think it's a good moment to ask it. You mentioned just a moment ago, Johanna, about awareness raising. Actually, there's a couple of questions about essentially about misinformation on the one hand. So how to address concerns about wrong information, misinformation, disinformation that's getting to undocumented people. And on the other hand, what steps are being taken in your different national contexts, or should be taken, to really get people reliable information about the vaccine, about how it works, about the practicalities of how to actually access it where that's possible. So this is a question for anyone in the panel who would like to jump in. But information, on the one hand, reliable, and what your concerns have been about unreliable information getting to people. Joe, please, and then Frank.
Thanks. Just very quickly, I think there are concerns in this context, and I think elsewhere on the continent, that it's less about the information people have about vaccines and how vaccines work and vaccine kind of hesitancy in that context. It's much more about vaccine hesitancy in the context of understanding, being fearful of the role of the state. I mean, I worry in some contexts that we've been speaking much more about the need to translate, to communicate around what a vaccine is. Sure, that's important. But for us, it's about how do you assure people of safety, but also how can we do that without that assurance being in place? So for me, there's other forms of communication, including with the state, around these issues. So I think it's about extending that in some way. Thanks.
Frank, and then Stephanie, please.
Yeah, good practice example of a salaried nurse together with her nurse volunteer colleagues in a local daycare center, and that includes a lot of undocumented visitors. They're going to make a video, very, very short, that they're going to ask all the people who come to relay on WhatsApp, just a short video. So we were thinking also about, can we mobilize undocumented migrants who could say something like, hi, my name is Mamadou, I live in that place, that region of Brussels. If you want to get vaccinated, you can come at that place and that time. I don't know, something that we can, because we've talked about access to digital information. Many trans migrants, for instance, they use smartphones, they use applications for refugees. So we're brainstorming about all this.
Stephanie, please.
Just to mention your point about information, because we have adapted information support in Santé Publique France for all people, not only migrants, but we take into account literacy, and so we have a lot of documents. We are in free access to everybody, and maybe I think we can share between us this document, because maybe we can improve with the other countries. It should be a good point, because we mentioned, for example, that we don't need your card, especially for undocumented migrants. We said that we can, you can be vaccinated without any card, identity card or nothing. We don't need that. But maybe we can improve our document with, if you have some, and maybe we can share if you don't have, maybe it could be a good point. The problem is that we don't have enough financial support, and we only have one video, for example, because you mentioned, Frank, is very important. The support is very important, and video are much better than than flyer or something else. So maybe this point is very difficult for us because our institute is in the crisis, and so it's not very easy to have enough financial support for this. If we can share and mutualize the documents, I think it could be a good idea.
Brilliant. Great. Thank you for offering to share that, Stephanie. Maybe one last question, and I'll give this one to Michelle before we turn to our closing. Michelle, there's a question about the European Union's role, and in particular, whether the European Commission has come out strongly on issues of equity. Is there anything that you're aware of that the EU has done around issues of vaccine equity?
Thanks, Alina, and also to the great discussion. There was a communication that the European Commission issued in October on vaccine preparedness, which includes, in somewhat vague terms, communities who are unable to physically distance, vulnerable socioeconomic groups and groups at higher risk, and possible priority groups for vaccine deployment. But that was already October, so we haven't really seen anything in particular more since then. And if you do a word search in that document, and we can include the link in the chat, there's no reference to migrants at all. What is interesting is the Council of Europe Committee on Bioethics published a statement in January calling for equitable access to vaccination during the COVID pandemic and all future pandemics. And what is interesting is that the committee says that the Council of Europe member states should develop strategies to ensure appropriate support and removal of barriers to vaccination for people in vulnerable situations. And it also says that the provision of vaccines to people without residence or insecure legal status should be clearly detached from immigration control. This is in line with the European Commission Against Racism and Intolerance General Policy Recommendation 16 on safeguarding irregular present migrants from discrimination. Basically, this is in line with the Council of Europe's robust recommendation on the firewall. So this is a reference that I think we can also be using collectively. We'll also share that. And we're also, just for your information, all of these kind of references and statements by EU or European or global bodies we're sharing in our monthly newsletter, so you can find the links there. One that I also mentioned in the chat was the European Center for Disease Prevention and Control, ECDC. They actually had 2 reports in October and December where they specifically referred to migrants and refugees. So it's important, but they're an EU agency. It would be much more important if the European Commission said something about this. We also have to bear in mind that the European Commission Migration Department has a whole pact on asylum and migration, where the main aim is, in a sense, to facilitate the return of people who are undocumented and prevent them from coming to the EU. So in a sense, that overshadows much of what we've been talking about today. But I actually wanted to highlight that Joanna's point of working at 3 levels on the legal entitlements, and then the second level kind of capacity training, sensibilization of people working on the vaccine areas, and then targeting the community, the awareness raising. I think it's been exceptional that we've spent most of our discussion today on levels 2 and 3, but we haven't had a lot of chance of talking about how do you actually get to the legal entitlements? How do you make the case? How do you make sure that the country actually has the vaccine rollout in place? And this is actually one of the most challenging issues. Once you have it in place, I think there's been a rich exchange here, and there's much more we could do in it. But we have to continue to collectively mobilize around it. So I'd like to thank everyone also for the discussion.
Thank you so much, Michelle. I think that's a very nice note to end on. And with that, I see my co-host has rejoined us. I just want to really warmly and sincerely thank the panel. It's been really excellent to hear your very, very rich insights on what's happening and what's not happening and what needs to happen to ensure genuine vaccine equity in the rollout of the COVID-19 vaccination program. So thank you again. And I turn it over to our co-host Luciano for our closing.
Thank you very much, Alina, really for chairing so well this webinar. It has been very interesting. Thank you very much to PICUM for this very nice cooperation with the Amity Alliance. I want to thank also all the speakers for the very interesting presentations and all the participants for being with us for about 2 hours. We know that is a bit long, but I think the topic deserved a little bit more time, and I really think that the results are very interesting. So we close here, and I hope to see you soon on another Amity Alliance webinar. I put in the chat the new dates, so we have interesting appointments in April and May, and I hope to see all of you there as well. So thank you again, and have a good evening.
Thanks, everyone.
Bye-bye.
Take care. Bye.
Thanks, everyone. Take care.